Imagine this. You're in the ED, the monitors are screaming, and a patient crashes. In that moment, a quick glance at the ECG tells you everything. Or, crucially, it tells you nothing you can defibrillate. You're looking at a non-shockable rhythm. For you, the emergency physician, these moments are, well, they're the ultimate high-stakes chess match, right? Where every decision about a cardiac rhythm directly impacts life or death.
And that's exactly what our deep dive is designed for today. Really, we're cutting through the noise to deliver the essential knowledge you need on two specific non-shockable rhythms: pulseless electrical activity, or PEA, and asystole.
Right.
These aren't just lines on a monitor. They represent, profound diagnostic and management challenges. Our mission is to sharpen your immediate decision-making skills right there in that resuscitation room, clarifying what they are, how to spot their precursors, and the absolutely critical interventions. This is for you, the frontline emergency doctor, to take control of those chaotic moments.
So let's frame these two then. We all know the shockable rhythms, right? Ventricular fibrillation, pulseless ventricular tachycardia. You grab the paddles, you deliver the jewels. Pretty straightforward, in theory at least.
Relatively, yes.
But here's where it gets really interesting, I think. PEA and asystole demand a fundamentally different approach. What's the core paradox, the key thing at play here that shifts your entire strategy?
Yeah, the crucial distinction, and where many clinicians can get caught sometimes, lies in that disconnect between the heart's electrical activity and its mechanical function.
Okay.
So with pulseless electrical activity, PEA, your ECG monitor shows organized electrical activity. You'll see QRS complexes, maybe P waves, T waves. It looks like a rhythm.
Looks like it's working.
Exactly. But the critical piece, the absolute non-negotiable, is that when you check for a pulse, a central pulse, there is none.
Nothing.
Nothing. The heart's electrical system is still firing away, but its mechanical pumping function has utterly failed. It's not generating any cardiac output. That's the electrical mechanical dissociation we talk about.
And asystole, that's the classic flatline, the complete opposite, isn't it? No confusion there, visually at least.
Precisely. Asystole is characterized by a complete absence of all electrical activity on the ECG. It's a true flatline, meaning there's no electrical impulse, so therefore no mechanical contraction, and consequently no pulse. It's the ultimate cardiac standstill.
So for you in the ED, the immediate implication is crystal clear. Because neither of these rhythms is shockable, electricity isn't your primary weapon. Not initially, anyway.
Correct.
So for both PEA and asystole, what is the immediate universal intervention, and why does that become the absolute cornerstone of your approach?
The absolute, immediate, and universal intervention for both PEA and asystole is high-quality chest compressions, period.
Right. Hands on chest.
Hands on chest. Since defibrillation simply isn't indicated for either, your immediate focus has to shift entirely to maintaining whatever meager circulation is possible through external means.
Buying time.
Buying time. Your hands become the pump, buying precious time while you aggressively search for and correct the underlying cause. That's the bedrock, the foundation of management for these non-shockable rhythms.
Okay, let's dive deeper into pulseless electrical activity, PEA, because it often trips people up, as you mentioned. There is electrical activity on the ECG. It can feel, counterintuitive not to shock.
It absolutely can, and that's the core challenge of PEA. The guidelines clearly define it as electrical activity on the ECG without a palpable pulse. You'll see those QRS complexes, maybe even a fairly normal-looking rhythm.
I think it's almost reassuring.
It can. But when you go for that carotid or femoral pulse check, and you must check, it's just not there. This forces you really to prioritize that physical exam, that palpation, over just what you see on the screen.
Don't trust the monitor alone.
Never trust the monitor alone for a pulse. And here's a critical takeaway for you, especially when you're managing severe bradycardias, maybe thinking about pacing. If you're attempting pacing, like transcutaneous pacing, and you achieve electrical capture, meaning your pacing spikes are consistently followed by QRS complexes on the monitor, it looks good on screen.
You think you've got it.
Right. But you still feel no palpable pulse when you check. Well, you haven't fixed the problem. In fact, you've now definitively established that the patient is in PEA.
Oh.
And your immediate next step must be high-quality chest compressions. That electrical activity without a functioning pump is PEA. Stop pacing, start compressing.
Wow. So even if you're actively trying to pace them back, if it doesn't generate a palpable pulse, you pivot instantly.
Yeah.
Back to full CPR. That's a huge practice point.
It is a critical one.
So what are the management principles once you've identified PEA and you're doing CPR?
Management for PEA is essentially two-pronged, running in parallel. First, and non-negotiable, is immediate, continuous, high-quality chest compressions with minimal interruptions. That's the cornerstone. Keep that perfusion going as best you can. Second, and equally vital for PEA, maybe even more so than other arrest rhythms, is a systematic and relentless hunt for and correction of reversible causes.
The H's and T's?
Exactly, your H's and T's.
Mhm.
Unlike, say, VF, where the primary problem is the electrical chaos, with PEA, there's almost always an underlying physiological issue that has caused the heart's mechanical function to fail despite its electrical efforts.
Right.
So you need to be thinking hypovolemia, hypoxia, hydrogen ion, acidosis, hyperkalemia, hypothermia, tension pneumothorax, tamponade, toxins, thrombosis, pulmonary or coronary. You need to be a detective and fast.
Running through that checklist while compressions are ongoing.
Absolutely. That's key to potentially reversing the arrest.
Okay. Now let's pivot to asystole. It's often seen as the most dire, right? The final rhythm. What does this flat line truly mean for you, the emergency doctor? And what are the unique considerations here compared to PEA?
Asystole is indeed the complete absence of both electrical and mechanical cardiac activity. It often represents the final common pathway of cardiac deterioration. The outlook is generally grim, we know that.
Yeah.
But what's fascinating here and really critical for you to recognize in the ED are the high-risk features that signal a patient might be progressing towards asystole. The warning signs before the flat line.
Ah, the pre-asystole state.
Exactly. These include, obviously, recent asystole if they recovered briefly, but also specific ECG findings like Mobitz type 2 AV block.
Why Mobitz 2 specifically?
Because Mobitz II often signifies a more severe block, lower down in the conduction system, often infraanidal. It's less stable, less likely to respond to things like atropine, and signals a higher likelihood of progressing suddenly to complete heart block and then potentially asystole.
Okay, that makes sense.
What else?
Complete heart block, particularly with broad QRS complexes, especially if it occurs after an anterior myocardial infarction. This often indicates extensive damage to the conduction system and underlying muscle, carrying a poor prognosis.
Right, suggests a big infarct.
A big hit, yeah. And another one, any ventricular pause greater than 3 seconds. That should really set off alarm bells. It's a significant harbinger of impending asystole or other dangerous rhythms.
So the real insight here is that your ECG isn't just a snapshot of this moment. It's kind of a crystal ball, potentially.
In a way, yes.
It's about catching the patient before they even get to that flatline point. But once active asystole is confirmed on the monitor and you've checked leads, gain, etc.
Yes, always confirm in 2 leads. Check gain.
Once it's confirmed, what's the immediate action?
Once active asystole is confirmed, immediate, high-quality chest compressions remain the absolute standard of care, just like PEA.
No shocking.
Absolutely no role for defibrillation here. It simply won't work. There's no electrical activity to reset. The urgency, however, truly lies in that proactive management for those patients at risk of progressing to asystole.
Right.
For patients presenting with those high-risk features we just discussed, Mobitz II, complete heart block with wide QRS, long pauses, even if they don't have overt adverse features like shock or heart failure yet, you must treat them aggressively. Treat them as you would someone with symptomatic bradycardia.
Get ahead of it.
Get ahead of it.
Yeah.
Don't wait for them to crash completely.
Okay. And in those pre-asystole scenarios, or even symptomatic bradycardia threatening to become asystole, what about pharmacological interventions? Atropine is often the first drug people reach for.
Atropine is indeed your first-line drug for most symptomatic bradycardias that might progress. It works by blocking the vagus nerve's effect on the SA and AV nodes, which can speed up the heart rate.
So it's good for nodal issues.
It's quite effective in Mobitz type I, Wenckebach, heart block, and third-degree blocks, where the escape rhythm originates high up near the AV node, narrow QRS escape.
But less so for.
It's far less effective, often ineffective, in bradycardias caused by drug toxicity, unless it's organophosphates, where massive doses might be needed. And critically, it's usually not effective in Mobitz type 2 block or third-degree block with a low escape rhythm, like one originating from the Purkinje fibers or ventricles, wide QRS escape.
Because the block is lower down.
Exactly. The block is often below the level of the AV node, beyond where atropine has its main effect.
Got it. Dosage.
The standard dose is 0.5 milligram IV push. Repeat every 3 to 5 minutes as needed, up to a total maximum dose of 3 milligrams.
And why the minimum 0.5 milligrams?
Be cautious with doses below 0.5 milligrams. Smaller doses can sometimes cause a paradoxical slowing of the heart rate, possibly due to central effects, before the peripheral vagolytic effect kicks in. And the 3 milligram total dose is thought to represent full vagal blockade. Also, just remember, it has a relatively long half-life, so consider that if the bradycardia might be self-limiting.
Okay, so if atropine isn't effective, or it's contraindicated, or just not appropriate for the type of block you suspect, what's next in the algorithm?
Then you move to second-line agents, usually infusions. Think chronotropes and inotropes like isoprenolone, isoproterenol, adrenaline, epinephrine, or dopamine. These directly stimulate the heart.
Right, direct stimulation.
And beyond those standard pressors and chronotropes, remember specific situations. Intravenous glucagon is crucial for suspected beta blocker or calcium channel blocker overdose causing bradycardia.
Good one to remember.
Aminophylline can sometimes be surprisingly effective for bradycardias related to acute inferior wall MIs, possibly due to adenosine antagonism, or in spinal cord injuries, or even in cardiac transplant patients who might not respond typically to atropine due to denervation.
Interesting specific uses there. Okay, and what about pacing? Because that's often a critical tool in these peri-arrest rhythms, particularly when you're trying to prevent progression to asystole or manage profound bradycardia.
Absolutely. Pacing is key. For profound bradycardia that's causing clinical instability or has actually progressed to cardiac arrest, there's even percussion pacing.
The chest thump.
Essentially, yes. It's
Oh.
a non-invasive, immediate option you can try while getting other things ready. It's particularly mentioned as potentially useful when you have profound bradycardia or even ventricular standstill, but you could still see continuing P waves on the ECG.
So the atria are still trying.
The atria are trying, suggesting some underlying atrial activity that might be thumped into triggering a ventricular response. The technique is simple. Firm, repeated thumps with the heel of your fist to the precordium, just lateral to the lower left sternal edge. Raise your hand about 20 centimeters, give a firm thump, repeat at a rate of maybe 60-80 per minute.
And the key thing here.
The key thing, and this cannot be overstated, if percussion pacing does not produce a regular pulse promptly, regardless of whether it seems to generate some QRS complexes on the monitor or not, you must start CPR immediately. Don't delay compressions if there's no pulse.
Right, pulse is the goal. Okay, and then transcutaneous pacing. That's much more commonly used, available on most monitors, defibrillators, and the ED.
Transcutaneous pacing, or TCP, is indeed quicker to set up than transvenous and is non-invasive. Standard procedure. Apply the pacing pads, usually in an anterior-posterior position, though right pectoral apical is an alternative. You'll set the device to demand mode pacing, typically starting at a rate of 60 to 90 beats per minute. Then the critical steps are: first, gradually increase the output current, milliamps, until you achieve consistent electrical capture.
Which looks like?
That means you see a QRS complex immediately following each pacing spike on the monitor, usually wide because it's ventricular pacing, followed by a T wave. Then, and this is paramount, once you have electrical capture, you must confirm mechanical capture.
Feel the pulse again.
Feel for a corresponding palpable pulse, usually the femoral or carotid. And here's that crucial point again, framed from the pacing perspective. If you get good electrical capture that fails to generate a pulse,
It's PEA.
you're essentially looking at pacing-induced PEA, and it mandates immediate chest compressions.
Yeah.
Turn off the pacer, start CPR. Also, vitally important, TCP is painful. These patients are often awake or semi-conscious. Be ready with analgesia and sedation.
Good point. Pain management is key. And just to round it off, transvenous pacing, you wouldn't typically be doing that during an active code in the EB, right?
Precisely. The guidelines are very clear that it's rarely appropriate to try to attempt to insert a transvenous pacing wire during cardiac arrest. It takes time, it's invasive, requires skill, and often imaging guidance.
Yeah.
It's usually reserved for post-resuscitation stabilization or in more controlled, typically inpatient settings, often after non-invasive methods like TCP have bought you some time. The ED focuses on immediate, rapid, life-saving interventions like CPR, identifying reversible causes, atropine, and TCP if indicated.
Okay, so let's bring this all together for you, the emergency physician listening. Speed and precision are always paramount in resuscitation. What are the absolute critical management considerations for PEA and Asystole that you need to carry with you into that next shift?
Yeah, the key takeaways for effective ED practice, I think, are pretty clear. First, the fundamental distinction. While both PEA and Asystole are non-shockable rhythms, remember PEA presents with some electrical activity but no pulse, while Asystole has neither. Both, however, unequivocally mandate immediate high-quality CPR. That's job one.
CPR first.
CPR first, CPR hard, CPR fast, minimal interruptions. Second, proactive management is paramount. Your ECG is a powerful diagnostic tool, yes, but use it as a predictive one too. Recognizing those precursors to asystole morbus type 2, complete heart block with broad QRS, those long ventricular pauses, is absolutely crucial for intervening early with atropine or pacing, potentially preventing a full cardiac arrest from ever happening.
So it really is about anticipating the worst and trying to get ahead of the curve. Don't just react to the arrest, prevent it if possible.
Absolutely, that's the goal. Third, always remember to treat the patient, not just the rhythm strip. This means relentlessly assessing for and correcting underlying reversible causes, those H's and T's in any cardiac arrest scenario, but especially crucial in PEA where something else is almost always the primary driver.
Look for the why.
Look for the why. And finally, when it comes to pacing for bradycardia heading towards arrest, rapidly deploy those non-invasive methods like percussion pacing as a bridge, or more definitively transcutaneous pacing as a temporizing measure. But never, ever forget the fundamental rule. If you don't generate a palpable pulse with your intervention, return to high-quality CPR immediately. Mechanical output, the pulse, is your North Star.
That's a great summary. This deep dive into non-shockable rhythms really highlights the nuances and the critical decision points for you in the emergency department. It's definitely not just about knowing what to do in the moment of arrest, but really understanding the steps that lead up to it and how to intervene early and effectively.
It really is. And maybe this raises an important question for you to think about. Considering how much information is potentially available on that ECG, even beyond just the basic rhythm strip identification, think about subtle morphology changes, axis shifts, interval durations, maybe even rate variability just before things go bad. What more can you observe in those nuanced details that could hint at those critical moments before the flatline, allowing you to intervene even earlier and perhaps truly reshape the immediate outcomes you see in your ED? What are those really early warning signs we might still be missing?